Hey everyone, and welcome to a special live edition of the Lipid Insights podcast, coming to you straight from the NLA Fall CLU here in stunning Scottsdale, Arizona. I'm your guest host, Dr. James Underberg, and I'm thrilled to be part of this incredible gathering of dedicated and forward-thinking professionals in lipidology and preventive cardiology. I want to welcome everyone to this CME CE accredited episode of the National Lipid Association's Lipid Insights podcast series. This activity has been approved for AMA PRA Category 1 credit and is eligible for ACPE, ANCC, and CDR credit. CME CE credit is provided by the National Lipid Association. Please go to lipid.org/lipidinsights to read complete accreditation details. So this weekend is all about sharing knowledge, sparking new ideas, and building connections that move our field forward. And we're bringing you right into the center of it all. So whether you're joining us in person here in Arizona or tuning in from afar, get ready for insightful conversations, expert perspectives, and a few behind-the-scenes moments you won't want to miss. So today, I am lucky and honored to be joined by colleagues of mine, Dr. Michael Wilkinson, Dr. Anandita Kulkarni, and Dr. Daniel Soffer, to discuss the topic of expanding the role of lipoprotein A in atherosclerotic disease. Just some brief introductions. Dr. Wilkinson is a board-certified cardiologist and lipidologist who directs the Advanced Lipid Treatment Program at UC San Diego Health. His expertise includes diagnosing and managing inherited forms of dyslipidemia and the primary and secondary prevention of atherosclerotic cardiovascular disease through risk factor management and lipid-modifying therapies. Dr. Wilkinson currently serves as president of the Pacific Lipid Association chapter of the National Lipid Association and is also on the National Lipid Association Board of Directors. Dr. Wilkinson's research interests include lifestyle change and novel drug therapies for patients who are at risk for cardiovascular disease, including those with cardiometabolic diseases and all forms of dyslipidemia, including familial hypercholesterolemia and lipoprotein A. Dr. Kulkarni is a national leader in the field of preventive cardiology and lipidology. Her clinical expertise lies in the management of complex lipid disorders, women's cardiovascular health, South Asian cardiovascular health, and cardiac imaging. A passion for research led her to complete an additional fellowship, the Doris Duke Clinical Research Fellowship at the University of Pennsylvania. With over a decade of experience within the field, Dr. Kulkarni has authored dozens of peer-reviewed manuscripts and articles. Her work has been published in several high-impact journals. She's an active member of both the American College of Cardiology, the American Heart Association, and the National Lipid Association. Dr. Kulkarni is currently serving as a clinical associate professor at Texas A&M University College of Medicine. And Dr. Soffer is a full-time clinician and educator appointed as associate professor of clinical medicine on the faculty of the Perelman School of Medicine at the University of Pennsylvania in the Department of Internal Medicine and the Division of Translational Medicine and Human Genetics. He's the director of education for preventive cardiology and clinical lipidology at the University of Pennsylvania and co-director of the Preventive Cardiology Fellowship Program at Pennsylvania Hospital and co-director of the SOM Foundations of Culinary Medicine and Community Engagement course. He's a clinical lipid specialist whose focus is preventive cardiovascular medicine and internal medicine. He's a diplomate of the American Board of Internal Medicine, the American Board of Clinical Lipidology, and a master of the National Lipid Association. So welcome all. Thanks for being here today. It's been an exciting meeting so far, and I think we're looking forward to all kinds of interesting debates and conversations as we go forward over the next 2 days. I want to jump right in and get started with our topic, which is lipoprotein A and the role in evaluating and managing patients with elevated lipoprotein A in the context of atherosclerotic disease, and start with Dr. Soffer. Dan, I was wondering if you might just give us an overview of how the molecule interacts with other lipid parameters, how we think about lipoprotein A, its structure, its function, and why it's such a concern for us right now.
Very good. Thank you, Jamie. I appreciate that introduction. I agree. The meeting has kicked off great. I love last night's session. That was really exciting. Throughout the introduction, you referred to this as lipoprotein A, and then I think I heard you say lipoprotein little a. And I think, during this conversation, you're going to hear it referred to differently. I want to start off by saying the nomenclature is terrible. We already have an apolipoprotein, capital A1, capital A2, and now we have an apolipoprotein, lowercase a, and a lipoprotein, lowercase a, in parentheses, right? So it's a shame that it's called that. The lowercase a comes from the original designation to antigen. And I think we're stuck with the nomenclature, but I think during this conversation, we probably all maybe abbreviated a little differently just for better flow. I tend to say LPA and lipoprotein little a. So that's what we're talking about. LPA, for those who aren't very familiar with it, I just want to give a little bit of background. It's a lipoprotein, like LDL is a lipoprotein. So it's a microspherical particle that carries cholesterol, similar to the way LDL does. It's an ApoB containing lipoprotein. So ApoB enwraps this sphere to hold it together, gives it its main structure. And then there's an extra protein bound to it that makes it very distinct from LDL. And that protein is referred to as apolipoprotein, lowercase a, in parentheses. And that protein acts sort of like this tail that's covalently bound to the ApoB on the lipoprotein particle. It's that tail that makes it a distinct particle, gives it distinct physical, biochemical, clinical properties that affects us in multiple ways. And it's the reason we're having this conversation today.
Great. So, that's a wonderful overview, and I think it's important for people to understand, and I think you were alluding to this, that lipoprotein A, or LPA, is LDL with this protein attached to it. I often, when I have this explanation and conversation with a patient, they think it's something else, completely separate from the typical lipoprotein particles they're used to. And so that concept that LPA is LDL with ApoA is a huge hurdle for people to get over, I think.
I want to add a little nuance to that, because I think those of us in this conversation right now, we're clinicians and we don't spend our time at the bench doing the research. But in side conversations I've had, I'm going to call her out right now, with Marlis Kaczynski, who is arguably the world's expert in lipoprotein little a. She has told me, I'm not sure that lipoprotein is exactly LDL, and I'm not sure exactly how the lipoprotein differs from LDL, other than she's not sure it's the same lipoprotein, meaning that the way it's formed or the way it's processed is the same, and whether it has all the same elements. But I think for this kind of conversation, I totally agree. It's basically LDL. It's a
helpful
with
way
this
to
extra
think
protein.
about it, because people often think it's a completely different entity, and indeed, the ApoA molecule may change the structure and function of the LDL it's adherent to.
Yeah, and it binds to ApoB, which is an important component of the LDL in how it interacts with other lipoproteins, and especially with other cells like the liver cell.
Great. So talk to me a little bit about why we care about it. I mean, you've done a great job of explaining what it is. So why does it matter?
At this point in time, we can say with a high degree of certainty that lipoprotein little a has a causative role in the development of atherosclerotic cardiovascular disease, calcific aortic valve stenosis, and probably also a subgroup of pediatric stroke. I think the first two clearly, the third one not quite as clear. But because it has this causative role, it represents more than just a marker of risk, but also a target that is necessary for us to, moving forward if we want to optimize the care of our patients at risk for ASCVD and calcific aortic valve stenosis.
Okay, great, great. So when we think about lipoprotein A or LPA and evaluating patients, we often talk about this concept of residual risk. Residual risk means different things to different people. The risk that remains after a treatment is initiated or an intervention is made. How do you think about LPA when you are meeting with a patient who has elevated LPA, and what's your way of thinking and evaluating this?
Well, it goes beyond LPA because all of our patients who are at risk for ASCVD have multiple factors that contribute to that risk. We always think of lipoproteins as the building block for the atheroma. And when we lower somebody's LDL cholesterol with our medications and with lifestyle changes, we have reduced their risk for serious cardiovascular events by an expected amount that's proportional to the amount of lowering that we achieve. Even if we make that zero, our patients still have the potential for cardiovascular disease. They're not building new plaque, but the plaque that they have still has aspects to it that can put them at risk for events. And so you can't eradicate cardiovascular risk simply by eradicating the lipoproteins that cause the plaque in the first place. In the case of LPA, that's even more true because the thing that we tend to measure when we're managing care is the LDL cholesterol response and or the ApoB response. And even when we make that go very low, there may still be residual risk because of the presence of LPA, especially when it's at a high level. Now, it's still the main tool we have is LDL lowering for those patients. And until we have specific therapy for LPA, we can't get rid of all the risk that that person has, all the modifiable risk.
Right. So you've been practicing a lipid-focused field for quite a while now.
Easy now.
For how long have you been measuring and checking LPA in your patients?
Well, I think because I started my lipid practice in a firmly established scientific lipid program, I would say that from day one, because the leader of our program, Dan Rader, has been on top of this from day one and was involved in some of the early science related to this. So it was built into our culture that this was an important regulator of cardiovascular risk and can affect the way we interpret the lipid and lipid protein profiles of our patients. So I'd have to say that from the time I first put on my lipid doctor hat, we've been measuring LPA.
All right. So you've been measuring it for a long time. How has your thinking and management changed over the course of your practice with regards to addressing LPA?
Right. So it has changed. I guess I hadn't thought about it in those terms, Jamie, but I think initially we used it simply as a marker to explain why some individual or some family seems to be at higher risk. We'd say, oh, this explains why you and people in your family keep having heart attacks at young ages. Check. We've figured that part out. Now we're going to treat you with the things we know how to treat people with who have cardiovascular disease. So we've been using it that way primarily. And the other way that we initially were always paying attention to it is those patients who come in, we put them on drug X. We expected a, Z % response, and it turns out it was Z divided by 2. They got a less than expected LDL cholesterol lowering response, and trying to find an explanation, we say, oh, we better check your LPA in that circumstance. And lo and behold, they have a high LPA. I say, oh, that's why you didn't respond as well to LDL lowering therapy.
Right. So I'm going to ask this question for everyone. I'm just curious what your experiences has been. When you see patients in your clinical practices who have elevated LPA, what % are being referred to you by colleagues for the elevated LPA versus patients who are self-referring themselves for elevated LPA versus patients who you find through your own clinical practice by measuring LPA and noticing it for the first time. So I'll start with you, Dan.
I, I feel like it might be split 50-50 between medical providers referring patients because of the LPA and self-referral. It's really extraordinary how much self-referral goes on regarding this. And I think it's because the conversation about LPA has really ticked up a lot in the last couple of years. So I think it's 50-50. And I think a lot of the clinical referrals are because our colleagues know that we're participating in clinical trials with LPA lowering drugs. And so they're referring them almost specifically for that.
Right.
One other thing is we're also an apheresis center. And so every once in a while we'll get a referral for, hey, should this person get apheresis for their high LPA?
Great. So Dr. Wilkinson, Michael, what about your experience? How is it splitting up?
Yeah, no, I've been really happy that we've been receiving a lot of referrals from primary care within our own institution. So I think that, over the years, we've done a really good job of increasing awareness around Lp(a) and spreading the word about the importance of screening for Lp(a). And so I would say, maybe a good 50% of my referrals are coming from primary care doctors within our institution. I do get referrals from colleagues in cardiology for those more extreme or challenging cases, the very high Lp(a) with repeat cardiovascular events, repeat revascularization. What more can we do? And just like you said, Dan, sometimes that's a question of, is apheresis a good fit for this patient? Some of those come from outside of our institution as well, from the region for apheresis evaluation. But then some self-referrals, like you said, from patients, absolutely. I mean, that's another thing that's great to see is the increased awareness just in the community and in our patients. So having their Lp(a) measured and then coming to see us, that's a growing part of the referrals that I'm seeing.
So the caveat here, we should let everyone know your center is considered one of the premier LPA referral centers in the country. So there's going to be a natural bias, I think, for people to find you, but it's great to see that you're getting a lot of local referrals from your own internal medicine network, which I think means people are getting screened at the primary care level.
That's
Michael,
right.
don't you have an LPA clinic? Is it a separate clinic for LPA?
Yeah, so I've got to acknowledge all the work of Sam Samikas and Joe Whitstam in building Lp(a) into our preventive cardiology practice, and Sam started the dedicated Lp(a) clinic at UC San Diego, which he continues to see patients as a part of that Lp(a) focused clinic. It's a part of our broader lipid clinic, so I see a lot of those patients as well, along with other people like Pam Taub, Harpreet Bhatia in our group, and so everybody is participating in the wealth of Lp(a) referrals that we have, which is fantastic. I mean, one of the things that is important to acknowledge about Lp(a) is its genetic basis and its high prevalence. So if people start testing for Lp(a), we think we're going to find about 1 in 5 of those patients with an Lp(a) somewhere above 50 milligrams per deciliter or 125 nanomoles per liter, and suddenly that's a big need. At least people need to know what they can be doing or what their primary care doctor can be doing or when it might make sense for them to see a specialist.
Great. I've actually had patients of mine ask me if they should fly out to your center to be seen. So you're spreading your wings nationally, which is great. So, Dr. Kulkarni, same question for you. Where are your referrals coming from? Are you seeing changes, evolution in that, and how does it impact the way you're caring for people?
Well, taking a step back, I think we've known about lipoprotein A for about the last 50 years. And I think at some point it was considered sort of fringe medicine. When I first came into practice about 5 years ago, I feel like I was doing the majority of the Lp(a) testing. And sometimes I would tell my patients, hey, when you get your annual physical done, ask your primary care doctor if they would throw it on, and I would write it down on a piece of paper. And some of those patients would come back and say, well, my primary care doctor doesn't know what this is, and they refuse to check it. And I've been hearing that less and less. We've worked with a lot of the primary care doctors in our healthcare system and encouraged them, when you see a new patient, just add it on to the annual physical. And I've seen over the last couple years an increasing number of referrals from primary care doctors. I also get, being part of preventive cardiology, a lot of referrals for high-risk secondary prevention, lots of recurrent events. And so we do a lot of the testing within our own clinics for those high-risk patients, and they often end up having elevated lipoprotein A. And then I think there's this new wave of patients who are really self-motivated and really want to be proactive about their health, optimize their cardiovascular risk. And so they're finding opportunities to test themselves and, want to have that discussion with their clinicians on how they can be proactive, which is actually a really nice thing to see in practice.
That's great. At the beginning of this meeting, a bunch of us had the opportunity to be casually interviewed about some of the things that we think are the greatest misconceptions in the lipid space. And my response was that many times when I tell people to have their lipoprotein A screened, or at least for a family member who's not my patient, they'll say, well, we tried and we're told we don't want to do it because there's nothing to do about it. And I always say it couldn't be further from the truth, because then you might not even ask people about their family history. There's nothing to do about someone's family history per se, but it dramatically contextualizes how you care for the individual. And so, and I think, as we'll discover throughout the course of this podcast, is that there are a lot of things we can do right now. And so I want to use that as a springboard to come back to you, Dr. Kulkarni, and indeed, we're decided we're all going to use first names here. And talk a little bit about where we are in screening, recommendations, their evolution, where you think it's going, and how you think we're doing in this space.
Well, I think one of the big things is this is such a rapidly changing area. Every scientific conference that I go to, there's always new data, especially over the last few years, on Lp(a). And some of the guidelines that came out are a little bit older and maybe haven't caught up yet. But looking at some of the guideline recommendations, especially from the European Society, the Canadian Society, and the National Lipid Association, they recommend screening for everybody, which seems to be more in line with what our current data show. I know the ACC-AHA 2018 guidelines recommended screening, high-risk individuals. However, I think we're due for an update, and hopefully in the next set of guidelines, we'll see the importance of screening everyone.
And you mentioned that last official guideline in 2018, LPA does get called out as a risk-enhancing factor. So they acknowledge that it's important. They just didn't take that leap of faith that you're leading to.
Right.
So how does that impact what you do in your clinical practice? Are you finding that at your institution, people are getting it automatically checked now when they come in for that first visit? What's happening?
I think it depends on kind of how you enter the institution and who you see. I think we're moving a lot closer to screening everyone, especially when we're throwing it onto annual physicals and things like that. I mean, my general recommendation is that everyone should get screened. However, when I see an individual who does have elevated lipoprotein A, particularly with a concerning family history or concerning personal history, I do spend the extra time to discuss cascade screening with them and emphasize, screening all first-degree family members, parents, siblings, kids, because those are families that are going to be high risk, where you're more likely to find individuals with elevated lipoprotein A.
Okay. So do you check it more than once in people? This is, we'll expand this out to the group, but we'll start with you.
So that's an interesting question. Initially I was very much, it's a once in a lifetime check, but now we're seeing a little more data on there are patients with borderline Lp(a) levels who may benefit from repeat testing. And in about a quarter of those patients, you'll actually find that they reclassify themselves when you retest them, especially when they have other underlying conditions that could affect the Lp(a) level, underlying inflammatory diseases, liver disease, kidney disease. So those are the patients that I might consider retesting in.
What about patients, women after menopause? Do you see any changes there with LPA?
So I haven't routinely tested. However, I do think that there are postmenopausal changes in Lp(a) levels, and something that we should explore a little bit further.
So, Michael, any thoughts on this?
No, I think you put it perfectly, and that's what's in the 2024 recommendations from the NLA. Is that's one situation in which you might consider repeat testing is for those with that LP little a, as we put it, in the gray zone. So
Right.
that's somewhere between 30 and 50 milligrams per deciliter. Because just like you said, it might come out above and or below that, and it can help with reclassifying their LP little a related risk. But I think that, just as you alluded to, we're learning more and more that there is some intra-individual variability in LP little a. It is mostly genetic, but there are things, like you said, that can affect LP little a levels. And so sometimes I think repeat testing is useful. So if you have a suspicion that maybe LP little a was higher than somebody's true baseline because it was measured in the setting of severe inflammation, they had a severe COVID infection or something where that's the time that their LP little a was measured, maybe repeating it does make sense to try to get at their true baseline. We don't currently have standard recommendations for repeat LPA testing on therapy, but I do it sometimes. I mean, we know that there are things that impact LP little a levels. Sometimes I'm interested to know how much LP little a may have changed after I start a PCSK9 inhibitor, or measuring LP little a with apheresis. I mean, that part is standard as far as measuring the impact of LP little a levels with apheresis. That's another time that we'll repeat measurements.
Dan, any thoughts on?
I
More
think
than one?
Anandita and Michael really summarized how the guidelines and recommendation statements have fallen in terms of when to do it, and at a minimum doing it once in everyone is really smart advice. And the variability in individuals is something that, even though we don't recommend our patients do serial testing, what we have seen is that you can have more variability than one would expect if it was purely a genetically determined variable. And we know there are environmental changes that can have an impact on the level. You touched on probably the most important ones: kidney disease, liver disease, inflammatory diseases, menopause, hormonal changes, not just sex hormones, but thyroid hormone. So there are variables like that. The other variable that makes it really tricky is we're not that great at measuring LPA. Exactly. It's a tough molecule to measure quantitatively with a high degree of precision. So that suits me just fine. I am not a dogmatic clinician, nor do I think precision has much role in taking care of humans. I think in general, biology has all kinds of factors that self-regulate that we're not in control of. And unlike engineers building a building where they are in tight control of each of the parameters, clinicians have a lot of wiggle room in general. So I like tests that give me wiggle room. And this test, by its very nature, gives us wiggle room. And what we do is we ballpark the number. So the specific number doesn't matter to me. Are they normal? Are they mildly elevated? Are they severely elevated, or are they extremely elevated? That's how I see it. And you rarely see people jumping from one category to the other, but some of those conditions that we talked about could cause that.
Right. So, and Adita, we talked a bit about screening. I was hoping you could briefly talk a bit about the metrics for measurement and how we've moved from milligrams to deciliter to nanomoles per liter, or at least are moving in that direction. Have you seen anyone come in with readings in the two different ways of measurement and then be upset about changes one way or the other?
So I've definitely seen patients that have had both measurements, and to be honest, sometimes I've had patients that had it checked a while ago in the milligrams per deciliter assay, and that might be another reason why I recheck in nanomoles per liter. In general, for the majority of patients that I've seen, if they're elevated in one assay, they're going to be elevated in another.
Right. Just that the number goes up and the patients get upset if they see a dramatic change one way or the other.
Sure. I mean, but then we explain to them the differences in the cutoffs and how
Absolutely.
the assays measure differently.
Yeah, great. Any other comments as far as measurement from you, Dr. Wilkinson?
Yeah, I think just like you both acknowledged, it is a test that has some limited precision, at least with currently available assays, but there are recommendations to move toward the use of the nanomole per liter assay. So I think we should all be working toward that, instituting that wherever we get our labs measured for patients. At the same time, I think we need to be just increasing testing. So that's one thing I try not to lose sight of is just test. I mean, whatever assay you have access to right now, just test, because as you said, and indeed, if it's high, it's high. If it's low, it's low for the most part. And we don't want to get too caught up in waiting for the perfect assay to start screening patients. We just need to screen now.
So that brings me back to the next big question, Anindita, which is we're all invested in this space. We're in practices and in clinical settings where other people know about it. But how are we doing in general with regards to testing and screening for LPA outside of our little lipid world here?
I think the short answer, unfortunately, is not well, but I do think that it's improving. I feel like this is gaining more and more traction. Like I said, I love when I have patients that come in, they've done their own research on Lp(a), and they want to be really proactive. And one of the more important things, right, beyond just the sheer numbers and you know the limitations of the assay is really the downstream effect of this, right? What are we trying to do? At the end of the day, I and my patient sitting across me want to lower their risk for heart disease. And so we take their Lp(a) level and we translate it into something that's more practical to lower their risk of heart disease overall. And so a lot of times, you know, our patients with elevated Lp(a) will, if they're of the appropriate age, will get a coronary calcium score to further risk stratify them to look for the presence of calcified plaque.
So it's going to impact additional screening.
Right.
And so once you find out the LPA is elevated in a patient, do you talk to them about screening other family members?
I do.
Okay.
So we talk about cascade screening of first-degree family members. We risk stratify them further, often with a calcium score, and then we use that data to aggressively lower their, you know, LDL cholesterol, but also all of their other modifiable cardiovascular disease risk
So
factors.
you're more aggressive about management in general once you know it's elevated.
Absolutely, across the board.
Right. Anything specific you're doing with regards to choice of therapeutics right now? We're going to get into newer therapeutics, but with regards to patients who have elevated LPA as opposed to those who just have elevated LDL, as an example, that might alter how you manage or treat people.
So it really depends on the category of patient, whether they're in the primary or secondary prevention category. From a lipid standpoint, you know, I really take the approach of what is the best way to lower your LDL cholesterol in the most effective manner.
Okay. So, Michael, I'm going to move on to you now. First, some thoughts on, you know, the way you think about managing people currently who come to you with elevated LPA. Obviously, we've talked already about screening and more aggressive risk assessment, but any other tools you have an apheresis program at your center? Any other medication choices that you make one way or the other?
Yeah, so just like Anindita said, I think it depends on risk. So that assessment of risk in the individual patient. So thinking a little bit differently about primary versus secondary prevention, but you know, acknowledging that we need to treat primary prevention patients as high risk primary prevention when we have other risk factors like high Lp(a) or evidence of coronary artery plaque with something like CT coronary calcium scoring. So standard lipid-lowering therapies, statin therapies, for example, are first line. Treating other cardiovascular risk factors, hypertension, diabetes. This is all a very important foundation of my practice and approach to patients with high Lp(a). But for those patients at very high risk, so that would include those with a history of cardiovascular events, I reach for things like PCSK9 inhibitors, which we know from clinical trials like Fourier, Odyssey Outcomes, are a very useful tool for lowering risk of recurrent cardiovascular events in all patients who fit that secondary prevention, high-risk secondary prevention group. And in post-hoc analyses from those trials, it looks like maybe the Lp(a) lowering that can occur with PCSK9 inhibitors may confer some benefit.
I wanted to ask you a question about this because we've all read those post hoc analyses of the the PCSK9 inhibitor outcome studies, the
Mhm.
Fourier and Odyssey outcomes. How much of it do you think is incremental benefit from LPA lowering from the PCSK9 monoclonal antibody versus that you're just identifying a group that's higher risk, and higher risk patients in all of the analyses of these outcome studies are the ones that seem to accrue greater benefit? And is there a way to be able to tell unless you actually truly have a dedicated PCSK9 inhibitor LPA lowering outcome study?
It's a great question. And I think, using post hoc analysis of these outcomes trials clearly has its limitations. But I think what we see in both of those analyses is the risk reduction fits the Lp(a) levels. So if you look at LPA levels and then you look at the portion of the absolute risk reduction that is attributable to Lp(a), it becomes more clear at the highest levels of Lp(a). So it's not just higher risk patients, but it really, I think those post hoc analyses have done the best job that we can to try to pull out those patients who are at highest risk because they have highest Lp(a) levels, and maybe those are the people that will derive some benefit.
So Dan, multiple analyses have shown us that you need to lower LDL 30 or 40% to really see a benefit with regards to improving cardiovascular outcomes. What do we know or think we know about LPA and how much you need to lower it to really change things?
Well, the real answer is we don't know at all. Now, I'm not a fundamentalist evidence-based medicine practitioner, but I do start with the evidence. And as of right now, we have exactly 0 randomized placebo-controlled trials showing the outcome of taking an LPA-lowering drug versus placebo.
So if you were going to design a trial, what would you want to achieve to at least have a good feeling that you are going to show benefit?
Well, I would love to use a drug that doesn't impact other things other than LPA, if such a thing exists.
Mm-hmm.
And I could really know whether LPA lowering with this drug compared to placebo is strictly due to the LPA lowering, assuming that there's no other off-target effects. We have some drugs in development that are pretty close to that, and we're starting to get to that point. Before we even get to that, there is some, if you look at the Mendelian randomization data, and Michael, you probably know this better than I do, but there is some suggestion that you need to lower the LPA by 40, 50+% to really have that significant impact on outcomes. And so even the drugs that are in development specifically for LPA, they all do that plus some.
Yeah,
then there's some other drugs that aren't specific for LPA that are also having that effect as well. So
yeah, I think Brian Ferencz has presented some data that you need to go even as high as 80%
Right.
to expect to see benefit. And of course, we don't really know how the LPA particle behaves in the artery wall. A lot of the modeling is based on LDL modeling. Yeah. So I just thought that would be a nice segue to come back to you, Michael, and to start talking about where are we going? What's out there in development? What are the clinical trials that are taking place right now? And I was hoping maybe you could just take us through a couple of them, maybe starting with pelacarsen, LPA Horizon, which is an antisense oligonucleotide. And then we could go through Ocean A and the ACCLAIM trials and some of the siRNA products that are out there to lower LPA.
Yeah, absolutely. And I think just like Dan said, this is what we need. We have drugs that are targeted Lp(a) lowering therapies that have demonstrated in earlier phase studies, phase 1, phase 2 trials, an ability to really potently lower Lp(a) levels. And, Lp(a), we've talked about its genetic basis, and, that goes back to the LPA gene. And the LPA gene is what encodes the apolipoprotein a that we were talking about, that tail that's attached to the LDL-like particle that creates an Lp(a) particle. And the targeted therapies, for the most part, so the RNA-based therapies are getting at that. They're getting at the production of ApoA by inhibiting the production of that protein, apolipoprotein little a, at the RNA level. So the first of this class of RNA therapeutics for Lp(a) that entered a phase 3 cardiovascular outcomes trial is pelacarsen, like you mentioned, with the Horizon trial. And pelacarsen is an RNA-based therapy that's part of a family called antisense oligonucleotides. And the ASOs are drugs that are specific for an mRNA. In this case, we're talking about the RNA that comes from the LPA gene for pelacarsen. And they're a molecule that is bound to something called GalNAc, which allows for very efficient uptake by hepatocytes. This allows for the use of lower doses of these RNA therapeutics. The drug gets taken up efficiently into the liver, and then it binds to that LPA mRNA, or the RNA that otherwise would have created an ApoA as a part of assembling that Lp(a) particle. The other RNA therapeutics in this space are siRNAs. So same idea, we're preventing the production of ApoA at the RNA level, but a different mechanism of action. So a different way in which that gene silencing or the targeted degradation of that RNA strand is achieved through the siRNA approach. So that's olpasiran, lepodisiran, zerlasiran, and all of these drugs now are through phase 2 clinical trials, and we can talk more about what we're seeing with efficacy and safety of these drugs. And for the outcomes trials, again, it's now pelacarsen with Horizon. You mentioned Oceana outcomes with olpasiran, the Acclaim trial with lepodisiran. So it's a really exciting space.
Yeah, and so kind of as a segue into diving a little deeper into these trials, I wanted to ask the group, anyone answer, what percentage of your patients who have a diagnosis of elevated LPA fall into the secondary prevention group, meaning someone who's had an event and finds their way to you, versus what I would call the primary prevention group, often someone who maybe has had a family member have an event and has been identified as having elevated LPA, and how that impacts their concern and worries around this diagnosis. So I'll start with you, Anandita.
So interestingly, I think about 30% of my patients are in the secondary prevention category, but I also run a general cardiology practice. And more recently, I've had an increasing number of primary prevention patients, attributed to the increased screening. So about 70% of them are in the primary prevention category.
Great. And Michael, you?
Yeah, I feel like it's been a gradual shift as more awareness. So we're seeing more awareness around Lp(a), so there's more people getting tested, so more self-referrals, primary prevention referrals. That's becoming a bigger part of my practice, but yeah, still a big mix of both.
And for you, Dan?
I probably have the same distribution, but my conversations are different depending on whether they're primary prevention or secondary prevention. I'm sure you have similar conversations, and I tell them I look into my crystal ball and I can see that Horizon and we can talk about whether to call it Ocean (a) or Oceana, but when that trial is completed, when those two trials are completed, and I think we're looking at late 2026, early 2027, somewhere in that ballpark for both of them, that assuming that those two drugs have successful outcomes, get FDA approval, we will now have a therapeutic option for our patients with established heart disease and high levels of LPA. But our primary prevention patients won't have access to those drugs unless they pay out of pocket. And so they won't even have access to those drugs until the Acclaim trial is completed. And that, we're talking, I'm going to harbor a guess of 2029, maybe, somewhere around that time, maybe sooner. Assuming that gets completed, that's the soonest they will have insurance approved, insurance authorized access to those drugs. And for our primordial prevention, we'll call them, the healthy young person with a high LPA, I don't know when that person will have insurance authorized access to an LPA lowering pharmacotherapy. You could be talking well into the 2030s at that point.
So you couldn't have verbalized it better, because I find that in my own clinical practice, it's the primary prevention patients within the context of a family member who have had an event who are the most worried. They, having that first event, as many of us know, could be the last event.
Right.
And I keep reminding them that the first two trials that you alluded to, the Horizon and the Ocean A, are both done in patients with pre-existing atherosclerotic cardiovascular disease. And there are some subtle differences to those trials, but typically the FDA approves drugs based on the enrollment criteria of the patients in the outcome trial. And so it would be surprising to me if there was a pathway for patients in the primary prevention space to be able to be placed on these drugs with insurance coverage. All that said and done, Michael, are there any differences between the first two, the pelacarsen trial and the olpasiran trial, with regards to study design, patient population that gives you food for thought one way or the other? And
Yeah.
I'm not asking you to put your neck out there.
No, it's important. There are important differences between the inclusion criteria and the study population for all of these trials now that are entering phase 3. So Dan mentioned the ACCLAIM trial has the high-risk primary prevention subgroup. It's the first time that we're seeing that in a phase 3 outcomes trial with these Lp(a) targeted therapies. The history of cardiovascular disease, so for the secondary prevention group, the inclusion is a little bit different between Horizon and Ocean A or Oceana. I heard the investigators call it Oceana, so that I've adopted that, but I was using Ocean A for a long time.
That was a source of conflict with me, and yeah, I thought it should be
It's the parentheses.
Ocean
I
little
mean,
a.
gives you pause.
Right? Okay. But pelacarsen, so here's the big difference between Horizon and Oceana. So Horizon is all atherosclerotic cardiovascular disease, both for inclusion and as a part of the primary endpoint. So that includes coronary disease, peripheral arterial disease, and ischemic stroke. Whereas Oceana Outcomes is a coronary artery disease trial. So you had to have had an MI or revascularization of the coronaries for inclusion, and the primary endpoint in Oceana is a coronary event endpoint. The ACCLAIM trial is a little bit different. That also includes events outside of coronary artery disease. And all three have a different Lp(a) level for inclusion. So above 70 milligrams per deciliter for Horizon, above 200 nanomoles per liter for Oceana, above 175 nanomoles per liter for ACCLAIM. So yeah, it's going to be interesting to see the differences in the event rates and in the endpoints for these different trials based on this design.
Any differences in the efficacy for LPA lowering between these different
Great question. Yeah.
medications?
So differences in efficacy and dosing. So that's another really important distinction. So starting with pelacarsen, that's the antisense oligonucleotide. So first of all, these are all subcutaneous injections. Pelacarsen is being studied as a once-a-month injection. And we saw in the phase 2 trial with pelacarsen about an 80% reduction in Lp(a), around that, a dose-dependent reduction in Lp(a), around 80%. With olpasiran, this is being studied as an every 3-month injection, and we saw greater reductions in Lp(a) up to 90+%, even approaching 100% reductions when we're talking about placebo-adjusted reductions in Lp(a) with an every 3-month subcutaneous injection. And then lepidisiran in ACCLAIM is being studied as an every 6-month subcutaneous injection and getting also 90% plus reductions in Lp(a).
pretty impressive. And indeed, they also lower LDL a little bit also, right?
Right. Right.
Yeah, so that's going to be interesting to be able to adjust out for that effect. It's not a huge
Is it the
LDL
same?
lowering.
Is it the same amount? I feel like there's some
Pretty
differences.
similar, I
Is
think.
it similar?
Yeah.
Subtle.
So you can't discount that effect,
Mm-hmm.
which is interesting. So I wanted to ask the group in general, I'll throw it out to everyone. One of the other things that is a little different between Horizon and some of the other trials is the inclusion of stroke, um, both as an inclusion criteria and outcome. And Dan, I think you alluded to the fact that LPA is clearly a risk factor for cardiovascular disease, and stroke maybe in younger patients. Do you think that stroke issue changes things? Do you think it plays a role in how these play out? Or do you think ultimately maybe not a big difference?
I guess it's going to be a mathematical effect because there is a different relationship between LPA level and coronary atherosclerotic cardiovascular disease and LPA level and ischemic stroke. So not the pediatric stroke notwithstanding,
Right.
that's a whole separate group. But in adults, the acute ischemic stroke outcomes really tend to only be seen when the LPA levels are very, very high. And so you don't get the same risk for ischemic stroke at more moderate elevations in LPA, and so that, depending on how many stroke patients are included in the studies, that can affect the outcome of the data interpretation.
And Adita, what's been your clinical experience with stroke versus coronary disease in patients with LPA, and also ages and maybe even some sex differences, have you noticed?
I think it's a little bit hard to tease out, partly because I think there's still a lot of undertreatment in general when it comes to stroke. I don't think stroke is necessarily a diagnosis that we as cardiologists embrace as much. And so, even when it comes to just basic lipid lowering therapy, there's a lot of gaps there. So I think it's really difficult to make a conclusion.
So it's definitely, I think, because of the variability in the drugs, their dosing, their efficacy, their trial design, it's going to be hard to compare apples to oranges so much. And obviously we await proof of concept, which is always the first thing, because we as clinicians are looking for other things that we can do. And so, I thought what I'd do is kind of take everything that you all have so wonderfully, verbalized over the course of this discussion, and kind of try to pull it all together a little bit. I think the first is that we as specialists in this area are very tied into LPA, the importance of checking it, the importance of talking to patients about what it means, and the importance of then instituting, as you pointed out, and Adita, the cascade screening, and having family members screened for elevated LPA. I think that one of the difficult parts of that conversation is talking to people about asymptomatic children. And if you notice, the NLA, Dan, in its paper, was pretty clear about all adults should be screened, as are the Europeans. But this is not a universal recommendation for children yet, and it can create a lot of anxiety and additional testing in otherwise healthy kids when we don't yet have a targeted therapy. So any thoughts on children from anyone here? Or what happened? Dan, you're nodding your head.
Yeah, it's complicated. So kids generally don't get strokes, heart attacks, aortic valve stenosis. They don't get these things until they're much older. There's that subgroup that I mentioned earlier of pediatric stroke. And if you tell a parent that their 5-year-old has a very high LPA and that there's a subset of individuals with a very high LPA who are at risk for stroke as a child, the risk goes from extraordinarily low to slightly more than that. And so I don't think you've improved the ability to protect children from having this horrible outcome.
Right.
All you've done is really raise the the anxiety of parents about this thing that their child may be harboring, and that really the reason to know about it in a child would be to give them advice on how to live a heart healthy, cardiovascular forward life over the next 80 plus years. And that's really the benefit of screening at a younger age.
Right.
And especially if we're not talking about just normal cardiovascular risk. If you're in a family where there's people having heart attacks and strokes in their 30s or 40s or 50s, now their risk is condensed in a shorter time frame, so they really have to pay attention to it.
And Adita, any thoughts on dialogues about children and screening?
So, I mean, to echo what you said, right? Pediatric patients don't necessarily get heart disease, but in some ways, I feel like not screening them kicks the can down the road. How many times have you had a patient come into your clinic with familial hypercholesterolemia and they're like 60 years old and never been on treatment, right? And so to me, I think knowing early on, it depends on how you frame the argument, and obviously it can cause a little bit of anxiety, but framed in the right way, it can also alert parents and kids to lead a much more healthier and active lifestyle and allow us to be more proactive about screening for other modifiable risk factors for heart disease. As we're looking at our preventive interventions, they're becoming earlier and earlier. We're focusing on primary and primordial prevention. So I think that this is truly the place to start. It's my understanding that kids get routine lipid screening between the ages of 9 and 11. And so to me, throwing an Lp(a) test onto the same panel at that time allows us to be appropriately proactive about it.
I think that was very well stated. And if you know, you can counsel appropriately. It's when I think people become over-counseled or, start doing other things they shouldn't. And a heart-healthy lifestyle for children, it just gives you another reason to be proactive in that realm. Anything important about, issues around pregnancy that you can think of for elevated LPA? Use of hormonal therapies. I always, of course, counsel my patients not to smoke, but we know LPA is prothrombotic also.
Yeah.
And so trying to avoid situations that increase the risk of people having thrombotic events is certainly something we want to try to counsel. Dan, you're shaking your head.
Yeah, what we mentioned earlier, that there's a causative association between LPA levels and atherosclerotic cardiovascular disease, calcific aortic valve stenosis, and ischemic stroke. But what we specifically left out was venothromboembolic disease. I think, and you asked me historically, what did I think about this? I think if you asked me about 20 years ago, I did think this was a risk factor for venothromboembolic disease.
That has changed now.
That has changed. So there does not seem to be an association with risk for DVT or pulmonary embolism, which comes up in as a pregnancy-related risk,
exactly,
and other hormone-related.
So really no concerns is what I'm going to.
Seem to be.
And I've had patients come to me and say, I've been told I shouldn't get pregnant because I have elevated LPA, and couldn't be further from the truth. And so we just want to make sure people understand that.
There are a couple of things related to LPA in pregnancy that are at least worth knowing about, though. I mean, Lp(a) levels do increase a little bit, or there's the risk that Lp levels will increase modestly during pregnancy. And we're learning more about this now, but there does seem to be some relationship between Lp(a) and preeclampsia.
Yep.
That's one place where there's emerging evidence that maybe women with high Lp(a) are at increased risk to develop preeclampsia during pregnancy. And as far as a mechanism behind that, I think that remains to be seen. But we're talking about things like endothelial dysfunction, prothrombotic or antifibrinolytic effects of lipoprotein(a). So that's the hypothesis, where Lp(a) and risk for something like preeclampsia may overlap.
So would you offer aspirin to a woman with elevated LPA who was going through a pregnancy?
I've given that a lot of thought recently, and I'm not sure what to do right now. Preeclampsia is...
It's a tough one. There is no answer, so
yeah,
I want to make sure our audience knows that.
Yeah,
These are the typical clinical decisions we're faced with all the time in practice. And Adita, what are your thoughts about aspirin, pregnancy, and LPA?
I think it depends on how high the Lp(a) level is, and maybe also what that family history is like. But I think it would be on a case-by-case basis.
So Dan, what about aspirin LPA in general? What are your thoughts there?
Can I just answer every question? It's complicated. It is complicated. I think, with regard to the pregnancy-related issue, I think the cardio OB these days keep having a lower and lower threshold for when they start low-dose aspirin during all pregnancies. And so I think that remains to be seen whether there's going to be an LPA threshold that justifies the use of aspirin. One little thing that physiologically about LPA and thrombosis that I know very little about, but I'm going to introduce it here, is that my understanding is that there's very little free ApoA in the circulation. It's almost all bound to a lipoprotein. But free ApoA seems to be more prothrombotic. And now I'm just quoting friends who do foundational science research, and I don't know that literature well, and that's what I mean. I know a little bit about it, but free ApoA seems to be more prothrombotic than bound ApoA in the form of LPA. And so that has some implications for drug development, right? So if we're using drugs that prevent ApoA synthesis versus drugs that prevent LPA formation, binding ApoA to the lipoprotein, there may be different implications if you're letting a high level of free ApoA remain in the circulation. That may be counteract some of the benefits of lowering LPA in that context. Not at the clinical level are we ever really ready to have a conversation about that, but in drug development, I know it's something that they think about.
So, Michael, you want to add to that?
Well, I mean, I think we should include in our conversation about clinical trials and drugs in development muvalaplin, which is the oral therapy that's being studied for Lp(a) reduction. And
how does that work?
It works by inhibiting that association between apolipoprotein a and ApoB100. So it prevents the assembly of the LPA particle. And interestingly, in the phase 2 trial with muvalaplin, the Kraken study, they perform measurements of both ApoA and the complete Lp(a) particle. There's a little bit of a difference in the reduction between those two assays, but in a measurement that's comparable to the studies that we talked about, so that measurement of reduction in the total LPA particle, they saw about an 80%, up to an 80% reduction, a little bit less than that, but dose-dependent reductions up to about 80% with muvalaplin. So, I think that's a really interesting and open question. If we have lots of tools with which to lower Lp(a), is there going to be, a difference for safety, efficacy that's going to depend on mechanism of action? I think we're going to learn that.
One of the things that I've noticed in the clinical trials so far, when we look at the global prevalence of elevated lipoprotein(a), it's approximately 20%. And there's certain pockets around the world where you do have a higher prevalence of elevated lipoprotein(a), particularly in Africa and South Asia. And one of the things that I've noticed is our clinical trial enrollment doesn't actually necessarily mimic the global prevalence pockets of elevated lipoprotein(a), including enrolling women. And I think one of the things that's really going to be important in addressing some of these questions is having more robust and representative enrollment of these patients, often who have some of the worst cardiovascular outcomes when they're untreated or undertreated.
And I think worth pointing out that Lp(a) or risk of elevated Lp(a) is higher in individuals of African ancestry and South Asian ancestry. And we think that the risk attributable to Lp(a) is similar, but if you are of African or South Asian ancestry, your likelihood to have high Lp(a) is increased. So it's really important that we have good representation of diverse populations.
Any sex differences in LPA?
So on average, so from epidemiologic studies, it looks like women are at increased risk to have at least modestly elevated Lp(a) levels compared to men, maybe about 10 to 15% higher LPA levels. So yeah, if we don't have enough women included in these trials or people of diverse backgrounds, then we're going to miss the opportunity to understand how these therapies work in those groups.
So, so we've talked about screening. We have a patient now with elevated LPA. And Adita, you were great about talking about how we focus on lifestyle and more aggressive risk assessment, and then more aggressive global risk reduction with everything we can treat. I've got two cardiologists here, so I want to ask both of you, does everyone with elevated LPA need an echocardiogram to assess the role of aortic stenosis, or are your ears enough?
I think my ears are enough for initial screen.
Okay,
Yeah,
Michael?
that's such a good question. Yeah, I think my ears are enough. At
Okay.
least that's
I'm
how,
asking it
that's how
because
I currently practice.
I've seen
Yeah.
recommendations that everyone should get an echocardiogram, but we still do physical diagnosis. I still listen, do my best. Dan?
Well, I guess, it's all because the only reason it's a question is because our threshold for surgical management of aortic valve stenosis is much lower than it was when you and I were just wee doctors, Jamie.
Yes.
And so because the surgical threshold is lower, I guess we want to know about aortic valve stenosis earlier.
That's true.
Even though we don't have a specific therapy to slow its progression at this point.
Yeah, I do want to call out, though, if you have a patient with a known history of bicuspid aortic valve, I think those patients need to be followed more aggressively.
Absolutely.
And Adita, what are your thoughts here?
Well, if there's a patient that has a bicuspid aortic valve, then there are screening recommendations for follow-up echocardiograms.
Right.
Even if they have a first-degree family member who has a bicuspid aortic valve, there's recommendations to screen those individuals. So typically, if we're following the guidelines, they would get screened.
And so would you be more vigilant in the context of an elevated LPA?
I would be. I mean, I would definitely listen a little extra harder.
And an important concept here is not only an increase in risk for calcific aortic valve disease, but an increase in risk for rapid progression of aortic stenosis. So when you find it, then monitoring more closely in those with high Lp(a) is important.
Right. And then finally, moving on to therapeutic choices. Right now, obviously, it's being aggressive about LDL lowering. We know that LDL lowering is blunted with statins and ezetimibe, and even PCSK9 inhibitors in patients with elevated LPA. We've alluded to the LPA lowering of PCSK9 inhibitors. Are you more likely to move to a PCSK9 inhibitor in a patient with elevated LPA after a statin if you need additional LDL lowering? And Adita, you're nodding your head.
I mean, my answer is yes.
Okay. Dan?
I think PCSK9 inhibition has a underutilized role across the board, not just in LPA patients. I think, it's a great therapy, and the only thing that keeps us from using it more is cost difference between a branded drug and the generic statins and ezetimibe. So yes, this is just a good reason to push for a little earlier introduction of PCSK9 inhibition.
And Michael?
Yes.
Okay. So I think this has been a great discussion. I want to give everyone a chance just to kind of throw in some final thoughts, points, wishes, hopes, dreams, etc. So Anandita, I'll start with you. You're sitting right next to me.
All right. Well, whenever a new lipid-lowering therapy is introduced onto the market, I've always seen us go through the same rigmarole of it being exorbitantly expensive. And it takes, being called out in the guidelines for lack of cost effectiveness and things like that for us to really see a difference in cost and coverage. And I think that elevated lipoprotein(a) and its management has gained so much traction. And I would hate to see that be slowed down when there are so many people that would benefit from this therapy. And I think that there is really a shared responsibility between us as clinicians to advocate for our patients, the insurance companies to cover these therapies when they become available, and for the pharmaceutical companies to make sure that they're also promoting access and equity when these therapeutics hit the market.
Michael?
Yeah, I absolutely agree. And I think, maybe related to that idea is just stopping for a moment and really appreciating the scope of the problem with Lp(a). I mean, this is unprecedented. We have an inherited risk for cardiovascular disease in the form of an inherited lipid disorder that we estimate affects 1 in 5 people. I mean, we know that familial hypercholesterolemia is common and underdiagnosed. We estimate about 1 in 300 people have heterozygous FH. But if 1 in 5 people have high Lp(a), we're going to have to be prepared. We're going to be really organized and prepared for how we're going to handle the introduction of things like new therapies. And there are so many of our patients who are looking to us for guidance in this space because, we are, I think, appropriately advocating for increased awareness and screening for Lp(a), but we need to be simultaneously giving clinicians and patients the tools to understand that risk and to give them the things that they can do now to help lower their cardiovascular risk because they're worried.
So Dan, I'm going to ask you for your final thoughts, but before that, I want to ask you if you have any concerns about LPA lowering, and then give us your final thoughts.
I think there could be some concerns about eradicating LPA entirely.
We don't know why we have it, right?
Right. There is some evidence that at super low LPA levels, there may be higher rates of diabetes, but I think that's going to be a manageable issue. So I'm not really concerned about that. That's about it, really, in terms of concerns.
So your final thoughts.
I'd like to express a little bit of optimism, Anandita. I would say that our past model of new things has been slowed down by the way we transmit information and the way we make decisions. And we now send information instantaneously about everything. In fact, this podcast may have already been broadcast and we haven't even finished it. So we transmit information much more quickly. And to the credit of the AHA, ACC, Multi-Society Task Force for Guideline Development and Prevention, the methodology for that guideline has changed to a more modular system, which means instead of waiting 6 to 10 years for an update to the guideline, on a regular basis, as new information rolls out, a module will be introduced to the guidelines. So I'm optimistic that will facilitate a sooner adoption of recommendations from guidelines on the management of LPA, assuming that these RCTs turn out to be positive and effective for reducing cardiovascular risk in our patients with high LPA.
All right. So I want to thank all three of you for a lively, interesting, informative discussion. Couldn't have been easier to get great conversation going. I want to thank our listeners for listening to this podcast. We hope you've enjoyed the discussion. You may claim CME CE credit by visiting lipid.org/lipidinsights. For questions regarding CME CE credit, please email cme@lipid.org. So thank you very much, and thank you to our discussants. We look forward to seeing you again soon.